A modern CT scanner captures intricate slices of human anatomy with sub-millimeter precision. Contrast that highly engineered hardware with the reality of functional spirometry, a diagnostic test where a patient blows forcefully into a plastic tube to measure how much air their lungs can hold. For patients suffering from fibrosing interstitial lung diseases, conditions that cause progressive lung scarring, clinical management relies on two main tools. Doctors evaluate the visual pattern of the disease on a high-resolution CT scan, and they measure forced vital capacity, or FVC. FVC is the total volume of air exhaled during a physical spirometry test. Relying on a human radiologist to visually estimate a CT scan introduces a distinct problem. The radiologist is asked to perform mental 3D integration of complex cross-sections and estimate the extent of fibrosis to the nearest 5%. That is a highly subjective perceptual task. In clinical trials, the failure of this human-centric approach is clear. When multiple experts are asked to evaluate the same scan, their inter-observer agreement yields a kappa coefficient of roughly 0.3. Kappa is a statistical measure of inter-rater reliability, where 0.3 indicates poor agreement. Combining subjective visual estimates with indirect, effort-dependent breathing tests creates a dangerous bottleneck. Medical professionals are forced to track a lethal structural disease using imprecise tools. Solving this requires a shift in how we extract value from a scan. We must move away from human visual interpretation and rely instead on the algorithmic extraction of the raw digital data itself. This approach is called Quantitative CT, or QCT. It operates as a suite of machine learning tools designed to convert unstructured voxel data into objective, reproducible imaging biomarkers. A voxel is a 3D pixel representing a specific value on a regular grid in three-dimensional space. QCT does not strictly look at an image. It mathematically dissects the attenuation properties of the scan, specifically how much the X-ray beam is reduced as it passes through different tissues, to build predictive models of disease progression. Because this computational approach evaluates the math rather than the picture, it allows clinicians to track a patient's response to therapy with high precision. It removes human bias from the evaluation loop. Establishing QCT as a standard enables precision medicine in pulmonology, providing an objective, prognostic data science for managing lung injury. A high-resolution CT scan contains massive amounts of unstructured attenuation data. This data extends far beyond the grayscale gradients that the human eye can process on a monitor. This 2D histogram illustrates early attempts at QCT. These algorithms relied on first-order pixel statistics, like calculating the mean lung attenuation across the image. They isolated a specific band between -600 and -250 Hounsfield units, which is a quantitative scale used to describe radiodensity. The critical failure of these early statistics is that they only measure density. They ignore the spatial arrangement and location of those pixels, making it impossible to map the actual shape of the disease. The modern algorithmic solution relies on texture-based metrics, commonly referred to as radiomics. Radiomics is the process of converting digital medical images into measurable spatial features that can be computationally analyzed. Instead of sorting individual pixels by density, deep learning models are trained on thousands of scans labeled by expert radiologists. The machine learns to analyze the spatial distribution of the attenuation values, allowing it to recognize complex structural organization in the tissue. Radiomics allows the algorithm to map the actual architecture of the disease, rather than just counting dense pixels in a void. This 3D wireframe demonstrates how modern QCT categorizes specific types of lung injury at the voxel level. The algorithm classifies individual features, separating reticulation, honeycombing, and ground glass opacities, rather than grouping all damaged tissue together. The baseline extent of these mapped fibrotic regions provides a readout of the total interstitial lung disease volume.
This exact volume consistently correlates with transplant-free survival, regardless of the patient's underlying radiological pattern. When applied to longitudinal tracking, QCT proves sensitive to structural changes over time. Looking at this split visualization, an increase in QCT fibrosis extent of just 2 to 4% over a 6 to 12-month period is an independent predictor of subsequent mortality. Here, the structural disease volume visibly expands by exactly 4.4%. This highlights a crucial clinical reality. This fatal structural expansion is caught by QCT, while the patient's functional FVC score shows only a minimal, ambiguous decline. The FVC trend line remains relatively flat, while the structural disease clearly climbs. QCT identifies fatal structural progression in the lung long before indirect functional tests signal a definitive alarm. This sensitivity extends to the earliest stages of the disease, identifying preclinical interstitial lung abnormalities. These are incidental radiologic findings of mild density that often precede clinical symptoms. In asymptomatic patients with minimal fibrosis, QCT tracks microscopic structural progression, such as a subtle shift from 4% to 8% extent. This metric predicts mortality years before physiologic symptoms appear. QCT also provides a path forward for indeterminate scans. These are cases where the visual evidence on the CT is so atypical that human radiologists cannot agree on a diagnosis. Advanced machine learning architectures provide objective decision support for these difficult cases. A multiple instance learning algorithm, or MIL, is a model that learns from sets of instances rather than single labeled data points. It uses patch-based analysis to isolate tiny sections of the scan and sort them by statistical probability. In these indeterminate cohorts, the MIL algorithm predicts histologic outcomes with an AUC of 0.79, outperforming human visual assessment at 0.71. AUC stands for area under the curve, a metric evaluating how well a model distinguishes between specific outcomes. These machine learning models identify prognostic patterns that remain mathematically invisible to human perception. If quantitative CT is objectively superior and highly predictive, why isn't it the primary endpoint in every clinical trial? The first major hurdle we face is the inherent variability of data acquisition across many different CT scanners and hospital systems. Radiomics is highly sensitive to input parameters. Minor variations in tube current, patient size, or slice thickness can alter the voxel data, which immediately corrupts the algorithm's reproducibility. One specific danger is iterative reconstruction. This is a common scanning software technique designed to reduce image noise and lower radiation doses. However, it introduces nonlinear effects on the image texture, confusing the radiomic model. This table outlines the parameters required to extract reliable QCT data. The scans must be non-contrast, acquired at full inspiration, and use a slice thickness strictly at or below 1.5 millimeters, with iterative reconstruction turned off. An advanced predictive algorithm is ultimately only as reliable as the physical standardization of the imaging scan feeding it data. The final and most significant barrier to QCT adoption is regulatory. Clinical trials and regulatory bodies like the FDA still force new imaging biomarkers to prove their validity by benchmarking them against FVC. This creates a fundamental mismatch in clinical evaluation. FVC is an indirect, effort-dependent physiological test. QCT is a direct, objective measurement of physical lung structure. Validating a precise structural metric against an inherently insensitive functional baseline severely limits the clinical understanding of how these diseases progress. QCT algorithms accurately predict survival and mortality, even in patients whose FVC metrics appear completely healthy. The broad clinical adoption of QCT provides the structural clarity necessary to accurately measure, precisely track, and ultimately treat fibrosing lung diseases.